Well, good evening, everyone, and thank you for the next episode of Daily with Nadira. And today, on behalf of Cardiovascular Innovations Foundation, I thank all of you for joining us. And I really have an exciting crew on with me. And let me introduce you to them. My first is Dr. Dwayne Pinto, who's going to co-moderate this session with me, who works in Beth Israel and is also the CMO of Jena Valve. The next speaker will be the first speaker, sorry, will be Dr. Omar Khalik, my fellow mentor from and currently working in San Francisco. We also have Harsh Golwala from OHSU as well, who will be presenting a case, followed by Dr. Ravi Ramana from Advocate Health. And it's truly a pleasure to be with them, my esteemed colleagues. And so the next frontier on aortic regurgitation. Now, the AR is really a common and undertreated valve. I thought the tricuspid is a forgotten valve, but really, aortic regurgitation is actually the other forgotten valve as well. We also know that a lot of aortic regurgitation patients aren't referred for treatment. And in addition to that, studies have shown that only 1 in 4 patients with severe AR actually receive surgery. And these patients can be really sick, and also they are at high risk of mortality, especially more than 70% at 5 years, especially for those patients who are really sick with class 3 or 4 symptoms. Now, how prevalent is aortic regurgitation in our community? So previous study by Dr. Gassel from Minneapolis here actually showed that actually nearly 2.7 million people in the United States have aortic regurgitation that actually requires treatment. And actually 4.5% of the population is actually about 65 or older, and these patients have significant AR. Now, the new guidelines by ESC just published like a couple of weeks ago showed that TAVR can actually be considered for the treatment of severe aortic regurgitation in patients who are symptomatic and not eligible for surgery. And this is a class 2B. On my left-hand side, you can see the algorithm. When you see someone with significant aortic regurgitation, what are the echo or even cardiac MRI parameters that you need to look out for and screen this patient who would need treatment, whether it's a transcatheter approach or surgical approach, and of course be seen by a multidisciplinary team. And without further ado, it's my great pleasure to introduce Dr. Omar Khalik, who will talk to us more in the next 10 minutes about the imaging parameters that is needed in aortic regurgitation. Omar, I'm going to stop sharing.
All right, thank you very much. Can you see these slides?
Yes.
Okay, good. So we're going to talk a little bit about imaging and aortic regurgitation. So currently, the US guidelines are a little bit further behind the European ones. So the guidelines base the treatments and diagnosis of AR on the echo parameters. So you see them here. And here you see the chart from the ASE valvular regurgitation guidelines published several years ago at this point. And we see the different parameters, so we'll just focus on those for a second. So if you look at the right-hand area of this chart, you'll see vena contracta width, that's 2D, 0.6 centimeters. Central jet width on color, greater than or equal to 65% of LVOT. Large flow convergence, right, very general. Pressure half time, less than 200. We know that one is somewhat unreliable. Prominent holodiastolic flow reversal, and enlarged LV, no values here. And then we see these other areas of the algorithm. So there are many parameters here, which is good, but it ends up becoming a very complicated chart. And as Nadira knows better than anyone, when we did the trials, actually, even after training the echo labs, many of these values were not acquired by the sonographer. So I think it's still a challenge to have such a complicated algorithm to identify what is significant AR.
You know, Omar, every time I see that slide, I have like an allergic reaction. But I think it actually fundamentally shows the disconnect between what is practical in real life, what can a sonographer and a reader do, and what people think should be done to make the diagnosis. And then I think it's also like impractical to have sharp cutoffs like this. Like, really, is there a difference between an EROA of 0.30 and 0.29, but 0.20 to 0.29, that range is okay? I just think that it's not like real world applicable. And I think that's what you saw in the trial is we tried to teach people. So I'm really happy that there are groups, and Nadira, you could comment, like the group in Texas that is trying to simplify the criteria. But, also you kind of have to be a doctor and see the patient and try to examine them and see what the difference is between the echo and how the patient is presenting. But no doubt, Nadira, you're probably one of the most experienced people on the planet to try to explain AR in echocardiographic terms.
Oh, I mean, Dwayne, thank you. I'm really humble. I think during the trial to all my PIs here, it was really challenging to discriminate between moderate and severe. And then you have the moderate to severe range. And I think there were a lot of discrepancies. And it was very challenging on echo. We were taught, I think, during this period of time, mitral regurgitation and then, of course, tricuspid regurgitation, but nobody actually really emphasized on aortic regurgitation until the trial, right, Dwayne? And
Yeah.
so that was when I think we had to go back to the psychs and emphasize on all these quantitative parameters because really in the real world, right, Omar, nobody was doing it. These
Yeah, I
parameters.
agree. I mean, I think you see on this chart, right, 2 to 3 criteria or 4 criteria. I think in many cases we struggle to even get those 2 to 3 criteria. I think
I
that's
mean,
one of the
that, yeah,
issues.
I mean, to be put a finer point on it, you can't have 2 to 3 criteria when only two are measured. You can't have 4 criteria when two are the only ones that are measured. And some
Right.
of this stuff, and I know the sonographers are asked to do like a complete study on everybody. So how do they actually go deep when there's something that needs to be done? But also too, there are some limitations of detecting things based on eccentric jets and those sorts of things. With this slide, it's in the fine print. You actually have to have a good echo in order to interpret this. So
Right.
I just think that, everyone takes this as gospel, but I think we really need to think about whether clinical judgment should be more important than, an EROA cutoff.
Yeah, and I think part of it is when, back in those days where we are not doing this as aggressively now, from, our experience with the clinical trial, I think that's why you have very late referrals of this aortic regurgitation patient, and then you have the high mortality with these patients when they undergo surgery, and also the LV regression as well, right, with the poor EF after correcting the aortic regurgitation. And so I think early catch of these, like any valvular disease, is certainly advocated. So, Omar.
Yeah, because the consequences of labeling somebody as moderate coupled with what we were taught, I think incorrectly, and maybe the other guys can comment, that you can just sit around with people with aortic regurgitation and it'll be fine. But the truth is, if they really do have severe aortic regurgitation and are symptomatic, you're going to show that it's not so fine. And if you just label them as moderate and we don't pursue the diagnosis, that's exactly why people are presenting too sick to get surgery.
Right. All
Yeah,
right.
so to move on to we'll talk about some of the things that we just discussed so we can look at it more. I would also question, right, even what's in the guidelines, how many echo reports for AR actually report, even in the real world, regurgitant volume, fraction, PISA, EROA. I think it's very, very uncommon. And the 99% of cases are just going to be reported visually, right, which we know there's a wider variability and easier to miss things, as you mentioned, with eccentric jets and other issues. And additionally, with some of the criteria based on echo LVEF, we know that the inter-observer variability is extremely high, right? As much as plus or minus 14%, so a huge range. And in many cases, this is also visual. So what I want to pose is really a move away from severe and moving towards significant, where some of the MRI data I'm going to show goes more towards this concept. So we know that the historical echo cutoffs for severe, on which the guidelines are based, actually are based on much less data than other data that we currently have, which are not yet reflected in the guidelines. Right, these are somewhat arbitrary and linked to correlation of color Doppler with LV angiography performed 40 years ago. The prognostic cutoffs, I think, are gaining traction. Much of that data is from CMR, which I'm going to show. And the thresholds we're still looking at, but I think we're getting really honing in on those numbers. And I think CMR is going to be a key modality moving forward to define this significant disease rather than this kind of arbitrary mild, moderate, severe. So really in CMR, the strength is quantitative assessment, and that means it's a normal part of the study, right? It's reported in every case, and it's just what is done in clinical practice. So the main two tools here are phase contrast and volumetric imaging. So super simple, right? Phase contrast, you basically co-locate this area at the STJ, and you get this region of interest, which you can see on the circle. You run this sequence and it gives you the forward flow and the backward flow. So in this particular image, right, total volume, we see backward volume, negative 46 ml, which gives us a fraction of 45%, which is from the forward stroke volume, right? So we just do a simple calculation. So 45% would be severe. Additionally, for more complicated cases, we can add volumetric imaging, which is based on the Simpson rule. So we get EDV and ESV. 4D flow is another tool, which is being developed now, which is in not research anymore, it's in clinical practice. So with these various tools,
or could you describe that a little bit more? Because
sure.
I find it very difficult when there's combined valvular lesions. Is this something that could help when there's MR and AR?
So yeah, so the advantage of AR actually is that even with combined lesions, the simple phase contrast tool, right, it's done at the point of interest right in the STJ. So there's really no interference from other valve lesions. But things like 4D flow could be additional check on that because sometimes with eccentric or swirling jets, there can be abnormalities with the phase contrast. Here we can use a 3D MPR like we're used to with many procedures and with CT, and we can line up the jets and get another measurement.
Omar, can I ask a philosophical question too?
Sure.
Why is it that all of us appreciate MRI is so much better than what we do, yet it's impossible to get it in a timely fashion? But if you twist your knee, you can get an MRI very quickly. What's going on?
Well, it's a good point. So the statistics show that the US has more MRI scanners per capita than any country on Earth. But what we don't have is the availability of trained techs and trained readers, right? Physicians who are trained with cardiac MRI. So that's really the limitation. So there should be access. Should be access to scanners, like you said, for any other type of thing, right? Neuro MRI, musculoskeletal, it's very available. But those same scanners, which could be doing cardiac, we just don't have the programs that have actually built the cardiac pathway.
Mm-hmm.
So what we do know is now based on this mounting data, which we'll go through, that the numbers we've kind of been given for echo, it turns out in many CMR studies, very consistently we run into the number of regurgitant fraction between 30 to 40%, which is correlated with poor outcomes, right? So that's kind of in the CMR world what we consider the quote unquote significant number. So, and this information is not new, right? This is 2012. So to show you how old it is, right? This is what I looked like in 2012. Here we had a regurgitant fraction cutoff of 33% for asymptomatic patients who then developed indications for surgery, right? So 33%, that was 13 years ago. This was a paper by the Minneapolis group a couple years ago showing basically exactly the same number, right? 32% regurgitant fraction. And even this has been shown in post-AS TAVR patients that with PVL 30, it's exactly the same number, basically 32 or 33%. So this number keeps coming out in the literature. This is another paper from the Houston Methodist group showing regurgitant fraction of 35%, again, for the combined outcome. And 38% of patients who underwent AVR within 3 months of the CMR did not meet the current severe AR criteria. And the most common reason for AVR was symptoms and heart failure, so a very clear indication, right? So we're missing many, many patients just based on these numbers.
You know, one thing too, Omar, is the follow-up on average for those patients was 2 years.
Yep.
And they underwent it, you know, SAVR or died. So I think it also adds to the understanding that these people aren't just people you can just park in, you know, in the back and not have to worry about them.
The mortality is definitely high for sure. We just saw the slide of the European guidelines. So these are some of the numbers that show up there, right? Those were 2025. So they're ahead of us and we need to revise ours based on all this data we're showing. The other thing that's interesting is that we sometimes treat these diseases the same, right? So AR and MR, look at the ASC guidelines, and you see that there are relatively similar numbers for the regurgitant fraction and regurgitant volume cutoffs, right? Those are exactly the same. We have
That's because they're totally made up, man. I mean, go back. Like, I mean, what are the chances that it's like exactly 60? That like all the hearts know it's got to be a round number. That's all made up. So, and then it just doesn't take into account the physiology that AR has an afterload badness component to MR. They're not the same, you know, regurgitant disorders to the ventricle. So,
definitely. So this,
you know, this is just
these data from Houston actually show exactly that, right? So with this kind of significant MRI cutoff of LVE DVI, right, indexed volume of 100 ml per meter squared, the AR patients achieved this at a lower regurgitant fraction, 40%, right? So again, the same number coming out versus MR, which required 50%, so it required a higher number. So indeed, these are different from the remodeling standpoint. We know that from this data from Nick Amoroso and company that AR patients are undertreated. Right? We already know this. There are very low rates of heart team evaluation. So 65% of patients who are diagnosed with severe AR had a referral, and 44% of patients with moderate to severe AR. So very, very low referral rates. And undertreated patients have increased mortality, which is separated at all levels of AR. And as Dwayne mentioned, the 2-year mortality was 21%, so very, very high mortality for these patients. And clearly the difficulties and confusion with the quantification, I think, play a huge role, right? The lack of understanding of what really constitutes significant AR. And some of the problems are inherent in our current cutoffs. We have something in radiology, right, where they have many of these things. These are the Fleischer guidelines, where you have, you know, these ground glass opacities and nodules in the lungs. And you have very clear recommendations on follow-up, right, rates of progression and follow-up. I think it's very rare to see that in echo, right? And with all valve diseases, the progression is not something that's thought about that much, and you kind of say, oh, well, moderate disease, and then you forget about it, and then they come back very, very sick, and then it's too late to treat them. So this is a huge problem. There was a J-Sky think tank a couple years ago, mostly focused on AS and barriers, but I think this is true of all valve diseases, and particularly AR, which, as Nadira showed in the prevalence statistics, is actually more prevalent than AS in the population. What we need is a partnership with echo societies, right? There was a recent reporting document, which actually from the ASE does include a little bit of this with these types of systems. And this, we called it AS-RADS, right? Something that tells you what is the monitoring, right? Repeat an echo in a certain number of months. And then of course, artificial intelligence, the big field is supposed to help us with all of this. So in summary, for aortic regurgitation, lack of recognition is a major barrier. Changes in guidelines on AR quantitation have severely lagged the mounting data. We're way behind. And the prognostic and treatment cutoffs by CMR are really clarifying into a very narrow range of numbers based on data on not only on prognosis, but also progression to symptoms and surgery. So that's pretty much it. I think we reviewed some of the topics that we started discussing, but a
Well,
lot more to discuss.
that's really nice, Omar. I'm also glad to see you're just as handsome in 2025 as you were in 2012.
Oh, thank you, thank you.
Yeah,
More seasoned.
yeah. But and I'm appreciative of all the work that you and others in the imaging community have done to shine a spotlight on this. My hopes are is that the guideline folks, both for treatment as well as diagnosis, hear what we're saying. That, frankly, I think it's been a failure of the guidelines to allow us to continue to be in this pathway of treating patients that hasn't been working. I'd like to turn it over with Nadira to Harsh Gowala. He is an interventional cardiologist at OHSU, Oregon Health Sciences University, and he's one of the most experienced genivalve implanters, as well as serving on the case review board with Dr. Ramana. So he knows and sees hundreds of cases he's seen now at this point and all the ins and outs, and he's going to be presenting a case to us.
Thank you, Dwayne, for the kind introduction, and thank you, Nadira, for the opportunity. So, first of all, Omar, great presentation, and I think it's clear that all the guidelines are focusing on, if you look at that chart, we have specific features of AI on the echo, but there's a big pool of moderate to severe AI patients, which there's no sensitive marker. And while we get caught on moderate AI post-TAVR being a bad prognostic marker, a moderate AI or moderate to severe AI in a normal patient, we consider as medical management. So I think that's a big gap we need to fill. With that being said, I'm going to share the case actually, I did this case a couple of weeks ago or last week. Can you guys see the slides?
Yes.
Perfect. So this is a standard 77-year-old female who presents with increasing shortness of breath on exertion and YHA class 3. Her comorbidities include hypertension, paroxysmal atrial fibrillation, chronic diastolic heart failure. She's on some Lasix, history of transient ischemic attack, and she has osteoarthritis with bad knees. Sorry, I cannot advance. Okay, here. So here is her echocardiogram. As you can see, this is a transthoracic. She has severe eccentric AI, and her EF is 60%, and she is feeling poorly. These are her Doppler parameters. I mean, in this case, she meets several specific parameters for severe AI. Her pressure half time is 200, and there's subtle diastolic flow reversal in proximal descending aorta. So this is her CT scan valve assessment. She has an annulus perimeter of around 83, and she has an LVOT perimeter of around 84, 85. And if you look at her valve, it's a tri-leaflet valve, minimal calcium. Her coronary heights are pretty normal. Our right coronary is 14, and the left coronary is around 12. Her sinuses are huge, around 30, 32, which is very typical for us to see in AI patients. So she underwent the heart team evaluation. Her STS risk score was 4.1%, but she was felt to be high risk of surgery given her age and frailty, as well as ability to recover from osteoarthritis after cardiac surgery. So what is the best approach in management of this patient? One option is palliative care. Second option, which I still see in a lot of social media as well, off-label TAVR with an oversized balloon on self-expanding valve, and there's a lot of discussions about should we 30% oversize, should we put a 2 size larger valve, which is very difficult actually. And all other options are dedicated transcatheter valve for aortic insufficiency. One of them we are discussing today is the Jena valve as a part of the ALIGN-AR trial, which was the high-risk trial. Our patients with high risk of surgery who had severe AI were enrolled in this trial. And then the other option is high-risk surgery. I'm sure all of the people who are on the call who have discussed with patients who are more than 75, they definitely do not want to go for surgery as well. So we decided that we would enroll this patient in the Yana valve, and we were fortunate she was accepted because, as you looked at the CT scan and the echo, she met all the criteria to have the Yana valve. So if I just briefly talk about the technology, it basically has 3 locators or clips which aligns in the nadir of the individual coronary cusp, the non, the left, and the right. And then there's a seal of oversizing in the LVOT with the skirt of the valve, which is kind of oversized as compared to the annulus as well. So this prevents the locators prevents the ventricular migration of the valve, whereas the oversizing at the level of the LVOT also prevents the aortic migration of the valve. The valve also has big open cells, so coronary reaccess, you can imagine it's not a problem at all. And because of the way the design of the valve is, there is automatic commissural alignment because you are into the nadir of individual cusps. So this valve is actually, if you look at from the TAVR standpoint, it's an ideal valve. It has good coronary reaccess. It is already commissurally aligned, and it has potential for future valve-in-valve options as well with more leaflet modification technologies. This is
the visual representation of nailing the nadir.
Right. So this is a sizing chart. This patient pretty much belonged to 25 millimeter valve. We went back and forth 25, 27, but I felt 25 would give us decent oversizing because she's right at the border. She's 83 and her LVOT was around 84, 85. So I thought that the 25 would give her a good seal with lower risk of pacemaker. So I decided to go with a 25 valve in this particular patient. And this is the procedural overview. This is the aortogram in the regular 3-cusp view, as we are all accustomed to. You can see severe eccentric AI filling the entire ventricle within a matter of a couple of cardiac cycles. And this is the on-table TE. As you can see, one of the cusp is really essentially flailing, and there's severe aortic insufficiency. So this is the first step. The sheath is pretty long and covers the entire ascending aorta, and we park it at the level of the sinotubular junction. So it's a pretty covered system, and the risk of stroke is minimal essentially. And these are the 3 markers, which are the 3 locators as we talked about. We check them at this level to make sure that while we advance the valve system, they are not having any issues. So this is a routine check for us, but this is just to show the audience that this is how the sheath is, the Safari VAR, and this is how we advance the valve inside a covered system across the ascending. Then there are certain functions in the valve system, which includes the flex function or unflex function, depending on what you need, depending on the size of the aorta as well as the angulation of the aorta. Once you do that, you expose the valve, you advance the valve into the individual cusps, and then you take pictures with each locator conformation in individual cusps. So as you can see in this picture, you can see this locator nicely in the left coronary cusp, and the leaflet is essentially on the left side of this locator as it should be. Similarly, this is the non-cusp. So usually the left and the non-cusps are easy to figure out. The right cusp requires usually a steeper RAO craniangulation to isolate the right cusp and then make sure that the locator is outside the leaflet or the right coronary leaflet in the right coronary cusp. Once we have this confirmation, we basically go ahead and deploy the valve. This is also, we still do a lot of procedures with TE, although it can be done clearly under fluoroscopic guidance as well. Usually on TE, we do the short axis view and then biplane through those different channels. You can also use 3D MPR if you want to get fancy. The anterior locator, which is the right locator, sometimes is very difficult to ascertain on the TEE. So definitely we go the RAO cranial projection on the fluoroscopic views to make sure we got the right cusp. The left and the non are pretty simple to see on TEs as well when you do the biplanes. Once we are confirmed, we usually pace at 180 and then release the valve, and then we retract the delivery system. So it's usually takes, once you get used to it, after our first 5 to 7 cases, we are able to do these cases in 35 minutes. So this is the post-deployment echo. As you can see, there's no AI at all. It really gives very large EOAs and amazing results. This is the gradient post-op next day, mean gradient of 7. And this was the aortogram on the table as well. As you can see, there's no AI at all, and with a great result. And patient usually goes home 24 to 48 hours, just like a regular TAVR patient, and they recover on the floors. So in summary, aortic regurgitation is a life-threatening disease. It has a 10% mortality per year in patients with symptomatic severe AI, 25% mortality, especially if the patient is NYHA class 3 or 4. Progressive LV dysfunction or dilation indicates mortality risk even in asymptomatic patients. It's a class 1 recommendation for AVR in patients with symptomatic severe AI, and class 1 recommendation for AVR even in asymptomatic patients with depressed LV function or LV dilation. And as we have more technologies which are safer, these thresholds are going to go lower and lower, as Omar and Nadira and Dwayne already discussed, that we need to revisit the guidelines in terms of what should be the cutoffs for moderate to severe AI to be more sensitive and just not specific, which is listed in these guidelines right now. Thank you so much.
Thank you so much, Harsh, for the excellent presentation and the case. For a question that I can think of, you see, we do this Yena valve and to the panelists as well. With TEE, do you envision this doing with transthoracic moderate sedation moving forward once the site has been experienced?
Absolutely. I think a lot of sites, I think I would say Dwayne might have better data, but I think a quarter of sites are already doing it mainly fluoro guided. And I think it's very easy to do fluoro guided as well. I don't see any reason why to do. And maybe, I mean, we haven't really explored, but there are some cases which are done under ice as well, if there's really a question mark. But in most of the patients, you should be able to do it with conscious sedation. I clearly see that in future, if not in immediate future.
Ravi, do you have a comment?
Yeah, no, I agree with that. I think obviously this device has a very easy learning curve, and so but the first 3 to 5 cases should be done both with fluoro and TE. We found in the beginning we really wanted to use TE, but as we got more comfortable with it, we got much more comfortable with fluoroscopy and using selective angiograms to make sure we had appropriate valve capture and position. So moving forward with moderate sedation in a fluoro-guided procedure and only using really transthoracics following the case for the other things like PBL or new effusions. I don't think you'd really use transthoracic to try to see if you have leaflets.
You know, around 90% of the patients in the pivotal study were treated under general anesthesia and TE. And we're seeing now, about 500 patients later in the CAP, that it's about 50%. But what I'll tell you is an interesting phenomenon, and it kind of goes to what our systems are. The 2 busiest sites in the United States, Cedars-Sinai and Columbia, almost uniformly use TE, even though they've done the most cases. And, you know, it makes you wonder, like, is the goal really to eliminate TE? When, you know, obviously they have, you know, very expert readers like Nadira and Omar, but, you know, we do see a wide range, for example, in the utilization of contrast. Dr. Vall at Columbia uses very little contrast because he can see and with echo and knows where he's putting the valve exactly. He can rotate little micro degrees to make sure he's lined up perfectly with the commissures with TE. So I think, and in Germany, some of the very busy sites routinely use TE as well. So I don't know exactly whether, you know, as interventionalists, we'd love to say how fast we do cases and how many cases we can do each day and all that sort of stuff. The average age in the trial was 77 years. You know, that's how long it took the person to get onto the table. Maybe we could spend 7 minutes extra doing it right, you know? So again, I know everybody wants to try to eliminate it. and it's annoying and all that sort of stuff. But some of the problems can be overcome with the system if it's better for the patient.
No, absolutely, Dwayne. I want to say that this was a part of the trial, and we have to make sure we have good outcomes specifically in the trial. This is a great technology. We want to make sure we use it right so that it continues to have good data set for good outcomes. And then I think once people do probably 25, 50 cases commercially, I think people automatically gravitate towards fluoroscopy. But right now, when we are in the data collection phase, we are supporting the new technology, which is really amazing. We should do the best thing to get the best outcomes.
Couldn't agree more. And I think we'll move on to our next speaker. Thank you so much, Harsh, to Dr. Ravi Ramana, who's also the PI of the LVAD registry. And it's a pleasure to have him on our call and present a case of the Jena valve TAVR for LVAD-associated aortic regurgitation. Ravi. Oh,
Ravi, you're on mute.
There we go. Is that a little better?
Yeah.
Yeah, great. Thanks again, Nadira, for having me. It's a pleasure to be here tonight and to be on this panel with a great group of docs. So I'm here to kind of talk a little bit more about LVAD-associated aortic regurgitation. So obviously, Harsh gave a great presentation about using JenaValve in patients with native AR, but as many of us see, there's a lot of different uses for that, and we'll get into some the future trials that are exploring that. But very early on at our center at Advocate Christ, a large volume LVAD center, the question early on to JenaValve was, could we be using this valve in different situations in a specific patient population of patients with LVAD with significant AR? We know from the data that's been presented over and over, mostly at the CHF and the LVAD symposiums, is that AR is a common complication following LVAD, and up to 25% of patients at 3 years have some form of significant aortic regurgitation. And this may be due to the failure of the aortic valve opening during the cardiac cycle, is known as the disuse theory. But it's also really important to know, and as an interventionalist, I didn't think about this until I had to, is that aortic regurgitation in a patient with an LVAD is much different than a patient with just native aortic insufficiency in a normal heart. And that's because aortic regurgitation in an LVAD patient is pancyclic. So there's a constant pressure on the left ventricle as the regurgitant volume occurs both through systole and diastole. And so that not only causes a constant gradient across the valve and further shear stress, and therefore progressive aortic regurgitation, but a constant load and pressure on the VAD to function. And that quickly deteriorates the efficacy of the valve, the efficacy of the pump. Mechanisms of LVAD-associated AR: increased diastolic pressure, again, leaflet immobility, where the valve does not move, leaflet microtrauma, altered root biomechanics, and an excessive unloading of the left ventricle. All of which left, as discussed, not only with normal AR, but left untreated, LVAD-associated AR can lead to heart failure that's refractory to LVADs and further advanced treatment and possibly need for a high-risk surgical AV repair, replacement, or even urgent cardiac transplantation. And we know even in a patient with a native heart, severe AR carries a significant morbidity and mortality as people are doing poorly. These patients that already have an LVAD with at least a second time in the chest, these patients can be especially high risk. So as seen in patients with native AR, these, I think, findings that we see as depicted from the Pantheon project of people trying to use, like Harsh mentioned, off-label valves for the treatment of significant aortic regurgitation. I think the Pantheon project is one of the better summaries of these experiences. Over 200 patients in 16 enrolling centers in Europe, evaluating patients with pure native aortic regurgitation with a normal heart. And we can see from the figure on the right that runs the gamut of different types of commercially available valves, from self-expanding to JenaValve to balloon expandable platforms. Again, to over 200 patients, the majority of these patients received self-expanding valves. And looking at the short term, only the short-term performance of this, we see extremely high rates of periprocedural complications, including valve migration and embolization at over 12%, having bailout strategies needing a second valve, or just having an unsuccessful procedure with significant residual aortic regurgitation, moderate or worse, and then, of course, a very high pacemaker rate. So at a combined endpoint of over 25%, so a quarter of patients undergoing these procedures had a very significant abnormal adverse effect at 1 year follow-up. And this is even more so in some of the smaller groups, patients that have been published on single center experiences with LVAD. So then it makes sense that maybe this dedicated platform, as Harsh has kind of alluded to, based on its technology, based on its centering mechanism by clipping to the valve and having a sealing skirt, may be ideal for patients with aortic regurgitation in a VAD. And so we had a case presentation that we implanted a few months ago, a 65-year-old gentleman with chronic systolic ischemic cardiomyopathy, had a HeartMate 3 LVAD placed in 2019 as destination therapy. And he'd been being evaluated by his primary cardiologist for potentially severe aortic insufficiency. He had reported pretty significant progressive shortness of breath and fatigue occurring to the point where it's affecting his daily life and minor activities of daily living. No chest pain, but then some progressive edema as well. His echo at the time revealed an ejection fraction of 15% and moderate to severe aortic valve regurgitation. A CT with TAVR protocol was completed. He was then referred to our valve team by the surgeons as well as the advanced heart failure for possible ENA for clinically significant AR affecting the function of the VAD. And despite any alterations to the VAD or any medical management, the patient's symptoms progressed. So the patient went through the screening process and was accepted for the ENA-VAD registry. Here are the pre-TAVR on the table TE images, as again, you can see and appreciate the constant pancyclic regurgitant flow from the aorta into the left ventricle. A typical 3-cuss view, as Harsh mentioned, again, really showing the constant load that it has on both the ventricle as well as the pump. And when we enter for for patients with LVAD, obviously the big concern theoretically is interfacing with the cannula, the LV cannula, but by usually just in our experience, flopping the pigtail in and making sure that our stiff preformed wire is placed behind or out of view behind the cannula and being careful on our in and out movements of our devices, we haven't had a problem yet. The process from there is the same as Harsh eloquently described, is simply getting the valve into place, lowering down to the level of the annulus, and then taking selective angiograms to try to make sure that we locate both the non-coronary, the right and the left coronary cusp. This is a little bit more difficult because obviously when the LVAD is functioning, the leaflets don't move, but we still get a better idea. And as you push down with the valve to interface with the annulus, we still see the same typical flaring of both the left and the non-coronary clips out. Once we've confirmed we're at the right level, we do have a soft protocol that we use within the trial. Obviously, looking through the literature and experience in Europe, as well as in the high volume centers in America, this has been done with some variation, sometimes ramping down on the LVAD and sometimes pacing. But for simplicity of the trial, we've asked the operators to follow the same protocol of ramping down the LVAD to about 4,000 RPMs just for the implant itself. And then rapid pacing, not necessarily rapid pacing at 180, but to 120 and 140. Again, this is just for a uniform protocol for the procedure to make sure that our results are generalizable at the end. But the implant itself and the release is very similar. The valve is released and we withdraw the device. As we see in patients with native hearts, the post-ENA implant is actually very, very predictable in terms of really no or trace paravalvular leak and good function. So this was our first case we did in the VAD registry. And after we implanted the valve, I asked the heart failure docs, just based on their expertise with the VAD, how do we know this is helping? And they really didn't have a numerical value on terms of what would we do. And they kind of shrugged their shoulders and said, let's see how the patient feels. So post-op day one, at 7 a.m., I saw him. He was a very optimistic person to start with, but he was already with big smiles, talking about how he felt so much better. Later that afternoon, I caught him walking multiple laps around our adult surgical heart unit, saying he hadn't felt this good in years. And a tearful wife on the second day on discharge said he hadn't walked like this, and I don't know how long. And so obviously this is what we do it for. And sometimes we have procedures that we need to do and have some clinical results, but the handful of cases we've done have been remarkable, very acute changes in these people's quality of life. Our 30-day echo showed that the ejection fraction was stable at 15% with no central or paravalvular leak. And now up to 5 months, he's reported continued significant improvement of his shortness of breath and edema, functional class 1 on most days, on 2 on his worst days. So this kind of leads to a JenaValve registry that we have within the confines of the JenaValve IDE trial, specifically looking at what we have been talking about and what I just depicted as transcatheter aortic valve replacement using the JenaValve in patients with significant aortic regurgitations in patients with LVADs. And again, importantly, to Omar's talk, to Harsh's talk, to all the commentary by Nadira, the expert of all things that leak on echo, it's important that we identified these patients as significant aortic regurgitation, because grading aortic regurgitation in the LVAD population is extremely tricky. And many of the LVAD experts that we have spoken to have suggested whatever looks like moderate is probably severe, and whatever is mild is moderate. And so, again, to Dwayne's point, being doctors again and trying to understand what are patients feeling, what are they presenting as, and what might be the cause. So the JenaValve registry started earlier this year. It's a prospective, multi-center, single-arm registry that's nested within Align AR. There's 10 centers in the U.S. All have been activated or nearly activated, and potentially up to 3 outside the U.S. We plan to enroll 50 patients and a follow-up of 1 year. Most importantly, looking at device success at 30 days in terms of freedom from all-cause mortality. Was the device deliverable? Did the valve go where we wanted, and no need for a second valve or any evidence of migration or embolization? Did we need a reintervention on the valve or an urgent cardiac surgery? And was there any significant paravalvular leak? And then obviously composite endpoints at 30 days for safety, including the typical mortality, stroke, VARC bleeding, kidney injury, and need for pacemaker. So in summary, clinical significant LVAD-associated AR is a common process in up to 25% of LVAD patients at 3 years post-LVAD implant. As we've seen, the mechanisms and the hemodynamic effects of LVAD-associated AR are different from non-LVAD aortic regurgitation. We know surgical AVR is an option for these patients, carries a very significant risk of morbidity and mortality. And the treatment of LVAD-associated AR with non-dedicated, commercially available TAVR devices, although has been successful in some cases, but has been associated with higher rates of migration, embolization, need for a second valve, and significant residual aortic regurgitation. And so the treatment of LVAD-associated AR with dedicated AR device, such as JenaValve, may be a safe and therapeutic option. And we hope that the JenaValve registry, which is currently enrolling, will provide more insight. Thank you.
Ravi, that was really good. Thank you, Nadira.
Thank you, Ravi. I'm going to put up the slides, but while I'm doing that, maybe Omar, you want to, before we close out with Dwayne, maybe you want to give us a brief, some, thoughts on the imaging for the AR in LVAD.
Yeah, so I think it's challenging. As Ravi mentioned, it's holocyclic, right? So it's a different quantification. So what people would visually call an echo as mild, right, is actually probably at least double that when you're considering the entire cardiac cycle. So things like 3D vena contracta area, multiplied by the velocity time integral, right, gives you a volume across the cardiac cycle. So I think some people take whatever they think and they upgrade it, but I think we can do more quantification than that, right? Even on the regular echocardiography. Now that we're not only in diastole, but we're throughout the cardiac cycle.
That's right. And also, with, for LVAD and for aortic regurgitation, we mentioned so much about, for the community to present more, maybe doing, being in the trial. How can we, like one of the questions in the audience mentioned, speak to the community, how to get them referred? Like for me is when I see an echo of moderate AR, just do another test, TE or cardiac MRI, just to get the better quantification. And of course, based on patients as well, symptoms and the clinical picture. But what are your thoughts about it, Dwayne?
Yeah, it's a really important, it's the most important question, actually, Nadira, is how do we get our patients to the right treatment? And I think, look, we're all super busy and we don't need extra jobs and that sort of thing. So what I think first we need to do is be more efficient in how we obtain the screening study, which is an echocardiogram. And, I would leave it to you guys, but I don't think it's practical to do every sort of measurement on every valve and the strain and the this and the EA and all these sort of things when the study is meant to try to figure out why someone's short of breath. So I think we actually have to tailor the study that's being done for what the indication is. We don't have to go super deep on that study on, what the longitudinal strain is of the right ventricle that appears pretty normal and waste the time on that. But the larger thing, I think, is, like you said, Nadira, if our patient is suffering, we're obligated as physicians to pursue the diagnosis and not to just give up when we read this summary of the echo report and it says that the patient's got moderate, whatever, AS, AR, take your pick. That person deserves a better test. It's a screening test. It's not actually, something that can make a definitive diagnosis right off. So I think that right there is probably the best thing to do, is to pursue the diagnosis for your patient. Then the next thing to do is actually send them to somebody who knows what they're talking about. I'm in the ICU, I'm a CCU attending. Listen, I can deal with DKA, but I also can call an endocrinologist and do a better job at dealing with DKA. And we are going to call ID for any little thing or whatever, but we don't actually send somebody to a structural heart specialist, which was what Nick's paper showed. Only 50% of the people have actually seen a member of the heart team when they have severe AR. So I think now that we have people who can do something about things and who have a deeper understanding, I think someone short of breath with moderate whatever, send them to the valve team.
Thank you. And would you like to talk to us more about the other trial that the Valve is?
I just want to, if you don't mind, I just want to add to what
sure.
Dwayne said. I think one of the more important points Dwayne brought up was almost becoming aggressive about trying to find the diagnosis. And my hope, and I think a lot of people that have been fortunate to be a part of the Align AR trial or been putting in valves are starting to get that edge on them, just like we did with aortic stenosis. When aortic stenosis and TAVR started, we might have just taken the original echo report and said, well, they don't quite meet severe criteria, let's bring them back in 6 months. But if our gut at the time said that there was something going on, we've had a decade of updating the guidelines, whether it was using contrast with echo or using calcium score for the valves, other things that can help us on indeterminate studies that could help give us information to say that this is time to treat the patient. So the hope is, the work that we're doing with the AR and the Align trial and the ARTIST and the LVAD will bring more knowledge, and then therefore when hopefully we have an FDA approved device, we'll have something in the toolbox for everyone to can use. So I applaud you for having this, and Dwayne, all the work he's doing trying to get the word out on AR and getting just as aggressive about that diagnosis as we are about AF.
Thank you, Ravi. And Dwayne, would you like to talk to us more about the ARTIST trial?
Yeah, so an ARTIST is really the natural progression from the high-risk population without good surgical options to a population where surgery is certainly a reasonable option. It's the guideline recommended treatment, as you mentioned, class 1 indication for a variety of these patients. So just like TAVR was established as a reasonable alternative to SAVR in aortic stenosis, that's what the purpose of this trial is. But what I tried to do a little differently here was not be ruled by the STS score, which, those of us who continue to take care of TAVR patients know that it's really quite wanting for really assessing risk. So I think we really can kind of tell the difference between, or the surgeons can certainly, somebody who's high risk for surgery and somebody who's not. This trial is for the people who are not. And if they're a candidate for SAVR and TAVR, then they can be in the trial. Now, it has to be an isolated bioprosthetic AVR. If someone's getting mechanical valve because they're really young, or if somebody's getting their mitral done because they have multivalvular disease, or if somebody's getting their aorta done because they have an aneurysm, or if the surgeon is capable of repairing the valve, that's not somebody for this trial because there's not equipoise. I can put a valve in somebody just like Harsh and Ravi can, actually not just like, because they can do it better. But, that doesn't mean that that's the right thing for the patient. So the heart team has to come together. I think this is real heart team surgical decision making. What's the procedure that this person needs to get? If they're 60 years old with Marfan's, then, maybe they're going to not be the right person for this trial. But if they're 70 years old or 90 years old or 80 years old and they're in good condition and their aorta is 4.9, then we can have a discussion about this. So we're going to go to up to 60 sites, and actually hot off the presses that we will consider with the FDA is an adaptive design. So we're going to look at the sample size and the data that we have and try to predict whether we need to reduce sample size or increase sample size. That modification is coming to your sites, Harsh and Ravi and Omar and Nadira. So the blue are the sites that are in process. Right now, we have about 10 sites that have been activated, more are coming along. But we hope to enroll through 2027 and then read out a year after last patient in. The trial design is the primary endpoint that you see there, a combined endpoint of all-cause death, all-cause stroke, and unplanned cardiac rehospitalization at 12 months. The primary endpoint is at 12 months, but we continue to follow the patients for 10 years with routine clinical follow-up and echocardiographic follow-up. These are key secondary endpoints where, it's a non-inferiority trial where we're going to show that we can do TAVR with similar clinical outcomes. But what also is the benefit to the patient of TAVR, apart from this notion of avoiding surgery? Well, if somebody avoided surgery but didn't do as well and it was worse for them, well, that wouldn't be a good alternative. But these 7 things here are things that we would think that we would end up being better on the TAVR side, making this an attractive thing for patients. And then one of the important inclusion criteria, or the 2 important inclusion criteria here, that if you have moderate to severe AR, assess the normal way by the normal bad way, which is with a crummy echo and perhaps guesstimation of how the bad the AR is. And Nadira, you could comment because you read all these echoes in the pivotal trial. But learning from your experience and us talking, Nadira, we are in a different situation now in this trial. Here, the heart team has already said, I'm going to operate on this patient for an AVR. You guys figure it out, but I think the person's a candidate for TAVR and SAVR. So as such, why don't you trust us and not treat the echo. And so with these kind of criteria of kind of a iffy non-invasive imaging study, but with an advanced imaging study, you really have done your best. But a sign that the ventricle is doing badly, and the heart team has already decided, the surgeon has said, I would do a SAVR if the patient weren't in the trial, then that patient can be enrolled. And that's our enrolling trial. The trial protocol is available with the key inclusion exclusion criteria, but they're very similar to the ALIGN AR study. Otherwise. And then Ravi, you are the PI of the GenEVAD registry. Any key learnings from, you mentioned the inclusion criteria is a high risk for surgery, as all VAD patients are, but any key learnings that you've found in this in the study so far where we've enrolled now 10, 12 patients?
No, I mean, I think 2 points to that. One, I think as we've gone along, as you know, a lot of the cases that have been brought or tried to brought to the registry to be included have been patients that are really sick. Patients that were hemodynamics didn't necessarily allow them to go through the whole process and therefore became compassionate use cases or real tricky cases, even on patients on ECMO. But these patients have had success. They weren't within the confines of the registry at the time, but JenaValve has done some work to allow an update to the revision to the protocol to allow some of these sicker patient, more urgent cases to be done within the confines of the VAD registry, which I think is going to be helpful so we don't feel like we're necessarily just cherry picking the cases, and to really show how important this technology is and hopefully how safe and feasible it is. That would be one point in terms of the patient selection. Another thing that I was reminded about as Harsh was presenting his cases, these patients are different, and obviously they've been through often a lot more than any other standard patient we treat. But based on their pathology, they normally have relatively small roots, and they're not dilated, and they often have reasonable angles. And so anatomically, we've found, at least, albeit in our small number that we've done with VAD, that it's actually an easier procedure to get the valve at the annulus because we're not reaching over with the left to try to grab the left coronary cusp in a dilated annulus. So from that standpoint, knock on wood, it's anatomically almost even a more straightforward case than a typical Jena case, which, as Harsh said, after 5 cases, you kind of have the language down. You can do it just as fast and efficiently as you do the commercially available devices.
Well, I think, Nadira, I'll make a comment and then maybe you can summarize us. But I think one thing that I've noticed now looking at all these patients is this dichotomy in TAVR for AR. The procedure is actually very similar as a TAVR procedure. It can be mastered within 4 or 5 cases. The doing of the TAVR is actually what we're used to. But it's the before, during, and after that's so different. The diagnosis of these patients is so different than the AS patients. It's so much more reliant on good imaging and trying to be a good doctor and devising the strategy that's right for the patient. TAVR has become just kind of very like routine, and you just kind of get the CT and the echo is easy to diagnose. But also too, these patients, they just manifest differently. They show up more of a burden of really decompensating heart failure. Their ventricles don't behave the same. And then afterwards, when I've been looking at these outcomes, it's become apparent to me too that even our understanding of how to track outcomes is imperfect with VAD and AR patients. After all, how do you describe hemodynamic valve performance when the valve doesn't open with a VAD patient? Is paravalvular regurgitation that's the same for somebody that started off with AR and you're really trying to bridge them to a next procedure? What's going to happen with MR in these patients? And if that person is a low risk person, should they get a double valve or should they get a sequential treatment? So all of these things are going to be new things in TAVR because the disease is totally different, as Harsh and Omar, really emphasized, and you have too, Ravi. But Nadira, I wanted to thank you so much for inviting me and for spotlighting AR. Really appreciate it.
Oh, thank you so much to my co-moderator, Dwayne, for moderating this with me. And to all my three panelists and speakers, thank you so much. To Omar, Harsh, and Ravi, absolutely the true frontiers of aortic regurgitation moving forward, the field forward. And I truly look forward to, Yena valve in the future for the dedicated, once approved by the FDA for aortic regurgitation, and we can treat more patients. And ultimately, I think to everybody on the call, thank you, and refer early, even moderate AR. Find out more, do MRI, do TE, because the earlier the referral, I think we can we can make them feel better. So thank you very much, everyone, for logging in. Thank you. Till next time. Bye.
Thank you.